Sam, I know you've done over 7,000 knee replacements, so you really are the man to ask. So talk to us about when a patient comes into you, how do you find out whether a patient needs a knee replacement?
Well, I think the key is firstly, you need to get to know the patient. You need to listen to them and let them talk to you about their journey. Very often, they've had symptoms on and off for many years, they've been managing, they might have tried lots of different therapeutic options, and they will tell you how their knee journey and their knee story impacts on their life. As in everything in medicine, the way you make a diagnosis is to take a thorough history, a careful clinical examination, and then special investigations. And in my world, special investigations are really a series of 4 X-rays and MRI scans. Occasionally we need CT scans, and ultrasound scans can sometimes be necessary, but mainly it's X-rays and MRIs.
Can I ask you, Sam, because most people that are watching that, if they've been to see their GP or seen another consultant, they often would just get one X-ray or 2 views of an X-ray. So can I just pick you up on there in terms of the 4 views? Because that's obviously something that you're quite specific about. Can you talk us through why you do that and what views you would use?
Yes, so a lot of people certainly around the United Kingdom, might only have a front-on view called an AP view and a side-on view called lateral, and they are 2 standard views. But knee surgeons also like 2 other views. That is, one is a skyline view of the patella, where you have a bent knee and you're looking at the kneecap and how that sits within the system. And finally, something called a Rosenberg or Schuss view, which looks like you are skiing. Your knee is slightly bent, and you take that. And the reason why
Is that weight bearing view?
it's a weight-bearing view. So the AP is normally weight-bearing, but the Schuss view is not only weight-bearing, but with the knee slightly bent. And that unmasks certain subtle signs of osteoarthritis. So largely, when somebody has a worn-out knee, they have 3 patterns of arthritis they will present with. The first is 60 out of 100 will present with the bow-legged deformity. Medial osteoarthritis, inner compartment has worn out.
So that's when somebody comes towards you and you can see they're slightly bow leg, which we call varus, don't we?
That's right.
But they're putting the pressure onto the inside of the joint.
That's right. And that pattern is a very painful pattern. And the patient normally comes early because they can't walk or it's painful walking. The slightly more subtle variety is the valgus knee, that is the knock-kneed variety. And this is where it is a disease of the flexor surface of the knee joint. So this is a right knee. The medial compartment is the varus knee pattern, but the valgus knee is the outer compartment. And there, the disease is on the flexor surface of the knee joint. So when you do a standing AP view, you often see a really well-maintained joint space. But the Rosenberg view or the Schuss view will show that the bone is touching.
At the front?
On the side.
On the side.
And often that patient will present initially with instability rather than pain, where you go from decent cartilage to clunk into the divot. And then only later on will they present with pain all the time. So
it's not uncommon that you get a patient that will see the GP and they've had a couple of views. They're in a lot of pain,
yes.
But actually they say, well, my GP said it was only mild to moderate arthritis.
That's right. And so the Rosenberg view unmasks that. And it's not uncommon to see a lovely looking AP with well-presented gaps and then bone on the Rosenberg. And then the final bit is, of course, the skyline.
Yeah.
Because 20 out of 100 people have kneecap osteoarthritis. And they're the people who can walk 100 miles on the flat, but getting out of a low chair or going downstairs or sitting in a car for long periods of time will hurt. And so that unmasks the kneecap variety. So if you get these 4 X-rays, you can then basically work out the wear pattern in the knee, and you can then start advising patients.
Because, if you think about, X-rays, they always say that should be your first investigation. But obviously with MRIs becoming more accessible, now you can self-refer for an MRI. I'm not sure how good they always are, but although I'm sure you do use lots of MRIs, do you think maybe there's actually too much focus towards MRIs when it talks about degenerative joints?
I have a practice where people travel a long way to come and see me, and so I like to cut down the toing and froing.
Yeah.
And so we, particularly in London, do what's called a one-stop service, where I have a master radiologist working in parallel with me, and we often X-ray and MRI before seeing the patient, because the patient will often come and say, why does it hurt in a specific place? And that's not always primarily because of the wear. It's often where the fluid is leaking. That's called a leaking Baker's cyst, or where the debris is, or where something is impinging around an arthritic knee. So I find if I have both the soft tissue view from the MRI scan and the bony view from the X-ray, I can answer all of the patient's questions on why their symptoms are so. And we can also then plan. And it's just really saving time and stopping patients coming and going all the time.
So, people say, I've got an arthritic knee, but quite clearly, arthritic knees are not all the same, are they? They're quite different. And I assume it's only once you get that clear diagnosis that therefore you can then give a bespoke treatment. So I assume they will have different treatment programs depending on the different wear patterns.
Very much so. It's very important to recognize that knee pain from a worn out knee varies from day to day, week to week, and month to month. And that is because of a few different causes of knee pain. The first is the patient gets a toothache type of pain from the worn cartilage surface, where the underlying bone is exposed and rubbing on bone on the other side. But that is not all. If that was the case, it'll be very uniform. The meniscus, that is the shock absorber cartilage, often is crushed and spat out of the joint. And sometimes as it protrudes from the joint, when your knees touch at night, it hurts. So you get a bit of tenderness.
Yeah.
Very importantly, you get debris in the joint, and the knee does the only thing it can do, which is to basically produce more lubrication on the inside. So in a healthy knee, in a young person, it might just produce 1 milliliter of lubricant, but in an arthritic knee or a worn out knee, it might produce 50 mils. And
hence you see the swelling.
The swelling, but actually you also see it leaking in weak parts of that bag around the knee called the capsule, and that is called a Baker's cyst. So many of the patients I see have a lump or swelling behind the knee or in different parts, posterior knee pain in the back of the knee. And when that leaks, it's exquisitely painful. So I've got many patients who manage their worn out knee, but when they leak from a Baker's cyst, their calf goes tight, their ankle might swell, they worry it's a deep vein thrombosis. And because they are then in severe pain as the bag bursts, they then come for an opinion.
Yeah. Absolutely. And so if we go back to the different views that you use, and you talked basically you can have wear and tear on the inside, wear and tear on the outside of the knee, and wear and tear
at the front.
So do you want to talk us through, now you've found out from that patient what you think the options are?
Yeah.
First of all, I suppose from a conservative point of view, what sort of options do these patients have?
Well, everyone gets told that conservative management of their worn out knee is a key part of the journey. I mean, these days we're treating the 100-year life. People are living a long time. And so you don't need to jump and operate on somebody. And everyone will go through their own journey of trying different things. Well, what are the principles of conservative treatment? Number one, you want to keep the joint moving well, keep the joint supple. Because if you operate on a gnarled up knee that doesn't move well and it's got contractures, then the end result is compromised. And you have to do more at surgery to get the knees straight. So the absolute fundamental is, even if the knee is wearing out, keep the joint supple. And that is what a physio should be working on, as you know, being a master physio. There is an overemphasis sometimes on muscle building and muscle strengthening, when from an orthopedic perspective, actually the range of motion is more important. Having good muscles is a good adjunct. People feel confident in their knee. And that is always nice to have. Simple analgesia, anti-inflammatories, paracetamol, ice, sometimes heat. They all help. But remember that they help because there are times when the arthritic knee is inflamed and there are times when they're not. And so that is a key part. Of course, being a master injector, that actually injection therapies have its place.
Absolutely.
Generally, they fall into three categories, in my opinion. There is the steroid injection, which is an anti-inflammatory agent, and it reduces the swelling and therefore the swelling-related misery for a period of time. There is the viscosupplementation, which is a cartilage protein gel, and the various different proprietary manufacturing of that. And that can go into the defects in the loss of cartilage surface, and therefore give some pain relief.
Yeah.
And sometimes there is evidence that if you mix those two up, it can last a bit longer than if you have one or the other. And then finally, there are the stem cell procedures, which patients seem to like to inquire about, because it sounds like
the Holy Grail.
The Holy Grail, but in reality,
Yeah.
The evidence is that it is probably just as good as steroid or
Yeah.
the viscosupplementation.
Yeah.
And at the moment, the evidence is that it is not superior.
Absolutely.
But these all have certain attractions and can be tried within reason.
And I think is what you said is, if you've made the diagnosis that there is osteoarthritis, we can't cure that. There's no injection out there, however much you pay for it, that's going to cure it. But you can manage symptoms, can't you?
That's right.
You can also, particularly if you think you're going to go and have an operation at some point, you can try and maximize your range of movement, try and get some strength, and try and go into that operation as strong as possible. Certainly here, from a physio perspective, we find that steroid injections, obviously overuse of steroid injections is not a good
bad
thing.
Yes.
But it can give you a window of opportunity to try and get in the gym and do some strengthening exercises, try and get slightly better range of movement. And there's no doubt, and I say this to my patients, is that the hyaluronic acid, the viscosupplementation, the steroid, the combination, if you've got a severe arthritic joint, very unlikely we're going to be making much progress. But there's definitely a group of patients, mild to moderate sort of changes. And, it is generally people that aren't overweight. That is something that we know there's very good evidence to support, that if people are a bit overweight, it puts a lot of pressure on their knee pain, a lot of pressure on their knee. But I do find there's a group that are quite active, not overweight, that are able to exercise still, that do quite well with injections and physiotherapy. And when I say physiotherapy, there's so many different types of physiotherapy. There's so many different exercises out there. One exercise program doesn't fit all. And I think it's very important that if you see a physio, that they are tailoring it specifically to your knee joint problem, be it range of movement or strength.
I fully agree. I think we also recognize that this is not just a physical journey, but it's a mental journey. And as people live with their joint that is wearing out and misbehaving at different intervals, I think the injections and the injectables form a nice adjunct to the things we can try.
Yeah.
But eventually the patient gets fed up, and they will know. Very often I say to the patient, you will know when the time is right, where you want a more permanent solution. And then we move on to, okay, well, what is that going to be?
So one of my questions later on is, when is the time right? Because that's such an important question, because I see patients that are 80 years old, they've got a really grotty knee, we're trying to manage it with injections, and we're doing okay with 2 or 3 injections a year, but they're having a diminishing effect, and they just won't have an operation done. And then you get the ones that, well, I can't run anymore, your 60-year-olds, and they're like, well, maybe I should have a knee replacement. And obviously those are two extremes, but when do you think the timing's right?
Well, I think there are certain things that I look for. So firstly, it's good to do it when the patient is fit enough to, for it not to be a too risky an operation. These days we've simplified this operation to make it quite straightforward. It really takes about half an hour or not much more than that. And so, but doing it when the patient doesn't have comorbidities is an advantage.
So that's when somebody, just explain what you mean there.
So
comorbidities.
what I mean is, if somebody gets frail and they've got lots of other medical issues concurrently, suddenly what is essentially a fairly straightforward elective operation then takes on new risks. So hanging on for the sake of hanging on is not a sensible thing. Secondly, I often work with a master physiotherapist who does what's called prehabilitation. That is basically stretching their range of motion to give us as best a range of motion in the joint as possible. Now, very often one would get to a limit. And if I send you somebody with, say, a 15-degree bent knee, that is a fixed flexion deformity, you might then ring me up when it gets to 5 and say, Sam, I've got it to 5, but actually I'm not going to get it fully straight.
Yeah.
it is now stuck because in fact the joint is gnarled up and it's got extra lumpy bits of osteophyte. The capsule is contracted, and then that the window is open to the prehab has done as much as it can, and now you need to get on with what you need to do.
Yeah.
I'm not a fan of lots of repeated injections. So of course, if somebody gets a really good result for about 6 months, then a second one is sensible.
Yeah.
But of course, some of these things, people sometimes hang on too long, and then they have a contracted knee. So, so I think the basic principles are, do it when the joint is maximally supple, work on it to get more suppleness before you go ahead, optimize your medical issues, and try and treat all of the other things and optimize it.
Yeah.
And do it when you're mentally, that actually you have to go through this small episode of getting better in order to then move on with life. And it's a mental journey, and the patients often know.
I literally had the conversation, where are we today, Wednesday, on Monday, I injected this lady, and she said to me, do you think I should have a knee replacement? And I was like, well, look, it's, we went through the pros and cons. I actually sent her our podcast from previously.
Yeah.
But a phrase that I often use is the pain in your knee and what you can't or can do as a result, is that affecting your quality of life? Is it making you miserable?
Yeah.
Does it mean that you can't go out with your friends? Does it mean that you can't go out with your family for a walk? And genuinely, if it is at the point where it is affecting your quality of life, then you have to consider it. But there is still, and I'd be really interested in your thoughts here, because I've seen so many of your knee replacements, and I would have a knee replacement, but I'm not lying. 15 years ago, I'd think twice about a knee replacement. So there is still a slight hesitancy, which you don't see with hip replacements.
No.
With knees.
I think you're absolutely right. I mean, when I started my journey with trying to get better at knee replacements, and I've now been doing it for, a couple of decades or more as a consultant, it was an operation that overall started off being only about 82% successful.
Mm.
And so I spent my life trying to do lots of little things that when you put together, you then have a much more successful result. The human hip replacement, in contrast, is, even if done averagely, is about 96% successful.
Wow, yeah.
So, and if it's done really well, is 99.9% successful. So you're starting off with a less painful operation, but I, in the knee replacement world, had to move the needle a lot more. And I realized that actually the only way you can do it is to put together a team that basically believed in marginal gains and improving constantly and learning and innovating. But also I realized that it was not just about surgery. It was about the end-to-end care of the patient, starting before you do it, getting them mentally and physically prepared for it, then doing it really precisely with all the innovation, and then looking after them. And getting them back doing things. So it's been an interesting, really, journey of constantly learning.
And technology, is that, the materials have changed, haven't they? The technology is developing. I assume that is part of it as well?
Massively. So I think there is a lot of misinformation out there. So in the past, patients were told, it would only last 10 years. No, implants have actually got very robust. They're made really precisely. They're lasting a long time, 25 to 30 years, maybe longer. There was a big leap in knee technology around the year 2000, where the polyethylene, which was really the bit that wore out, the manufacturing of that changed, where it was made in a vacuum or in nitrogen. And that meant that the poly didn't wear.
Right.
And there have now been subsequent leaps to technology where the way it's made makes it wear even less. So one is more confident in doing it on younger people and in slightly more high impact situations where you allow them to ski and play tennis and play golf and lead an active lifestyle. Of course you want their implant to last as long as possible, and they're living to 100 or more. And so you want to minimize the subsequent impact down the line. But certainly technology has improved a lot. And
you do hear, I go to see Sam because he uses a robot. There's a lot of robotics coming into surgery, which I think probably for laymen, they probably sit there thinking there is literally a robot doing the surgery. Yes. But do you want to just talk us through that? Because I know it's something that you have adopted you were one of the first to adopt it.
Yes. So I had the first Rosa robot system, which is Zimmer Biomet's robotic system. Robotic surgery is really robotic assisted surgery. And there are some significant advantages, but of course there are also some disadvantages, like anything in life.
Yeah.
The advantages are that it allows you to know where the leg is in space. So it allows you to know where your hip center is, where your knee is, where your ankle is, and it allows you a very, very precise way of knowing what the deformity is, and then what you've corrected the leg to. So it's a wonderful alignment tool, and gives you some
like
information.
a checker system in a way.
It's a checker system. It's like having a sat nav, really, that is very accurate.
Literally, isn't it?
And it is. Of course, the disadvantage is it takes a little bit longer.
Yeah.
So in my practice, if I use the robot, it takes me about an extra 10 minutes or so.
Right, yeah.
And without that, the surgery takes about half an hour, and with it takes an extra 10 minutes. And that may or may be an advantage for the patient. So I try and give the patient an idea of whether, in their unique case, that is an advantage or a disadvantage. If somebody's diabetic and they've got other comorbidities, actually that extra time may leave the knee exposed a little bit longer and be a disadvantage.
Oh, right. Okay, yeah.
Whereas on the other hand, if somebody is very fit and well, then it might then be an advantage. Now, it's important to also state that robotics are at the beginning of their journey we're not at the end, this is the beginning. And eventually, as we get better and better at it and the technology gets better, it will simplify other things. So there is a balance to be had, as in any technology. And I try and give people a balanced view, because everything else is marketing, really. And you want to stay away from that. And, it's a great privilege to be trusted. And that means you've got to tell people exactly the pros and cons of every
which will lead us in a minute into talk about getting prepared for that knee replacement. But one thing, our patient, the patient I was talking to on Monday, actually, they've got wear and tear specifically on the medial aspect of the knee. And I know that she was talking to me about whether she needs to have a full knee replacement or what we call a sort of unicompartmental. Do you want to just talk us through your decision making around that? Because there's no doubt that patients seem quite happy when you say you don't need to have a whole knee.
Yeah.
But just talk us through that.
So the first thing I would say is the word knee replacement sounds very scary.
To me, it sounds like you're going to do this. Chop off that bit.
Yes.
Chop off that bit.
Yes.
And just replace the whole thing. But that's just not the reality.
That's not the reality. In effect, a new knee is really like going to the dentist and having a crown fitted on your tooth. And what we're doing is skimming off the surface and custom fitting something that mimics what they had when they were young and making it look and feel natural to them. So you're always trying to guess what their knee looked like when they were 20.
Right,
and you're trying to custom fit something that balances the knee to give them the kind of shape and feel of that. And
so maybe we should rephrase the total, it should be total knee...
Resurfacing.
Total knee resurfacing, not replacement.
That's exactly right. And actually, indeed, if you do the same thing on the top end of the femur, we indeed call it a hip resurfacing.
Yeah,
and if you do that on the bottom end of the femur, we call it a knee replacement. So it's important to know that this is a resurfacing.
That feels very different, doesn't it, for patients, though? Replacement versus resurfacing immediately sounds less painful.
Exactly that. Now, the second thing is that in osteoarthritis, you can wear out 1/3 of the knee, 2/3 of the knee, or 3/3 of the knee. And these days, it's very easy to work out with an MRI and X-rays whether it's 1/3, 2/3, or 3/3.
Yeah.
And if it's a 1/3 wear pattern.
So do you mean on the inside? So just talk through what you mean by those thirds.
So the thirds are really, there's a medial third, a lateral third, and a front third.
Behind the kneecap.
Behind the kneecap, the patellofemoral joint. And so I tend to image people carefully, and then we examine them carefully and see whether, and you can feel all of the different parts of the knee when you examine them.
Yeah.
And then you know which third is reproducing pain. And if the disease process is in more than 1/3, I tend to offer them a full resurfacing of the knee rather than 1/3, because otherwise they might be delighted for a short period of time, and then they come and say, I'm sorry, it now still hurts going up and down stairs, at the front of my knee. And that seems a shame, because the best chance of getting this right is to get it right the first time. And if they have repeated surgery, it's more difficult. You're going through scar tissue. They've had a miserable journey, and it's not easy. Now, if they have isolated unicompartmental disease, then a unicompartmental operation is a very reasonable and nice operation to do, and I enjoy doing that.
Yes.
The final bit is to make sure that they don't have a systemic disease like rheumatoid arthritis or psoriatic arthritis, which actually is a process that dissolves the entire joint. So again, you just have to make sure that whatever you do works in the long term.
Yeah. Yeah, you don't want to be going through all of this, having a half a knee, as some people will call it, and then in 6 months you've started to get pain on the outside.
That's right. And the colloquial half a knee is really a 1/3 knee. So if you have that, then often you recover a little bit faster, and it might feel pretty good, but actually you've got to make sure that you are comfortable that the other parts of the knee are not going to produce pain, not only now, but in a couple of years' time.
Yeah, absolutely. Okay, so let's say they've come to see you. You've decided, let's say you're going to go for a total knee or knee resurfacing. I mentioned a phrase to you earlier, which I was reading an article about, before any operation, you have to prepare your mind, your body, and your home. So I'd be really interested in, and I'm sure there's people watching this that are booked in for a knee replacement. What are your sort of top tips for those patients in terms of getting ready and prepared for that operation?
So I think we talked about the physical aspect with the prehab. The mental aspect is very important, but remember that these patients very often have tried other things.
Yeah.
And they know they are unable to play golf or enjoy it. They're suddenly finding that skiing with their family is painful. And so they're wanting to move on with a different solution. So their mental strength, they've often made that decision, and they've tried other things. Preparing their home is very important. I mean, these kind of things don't fit neatly into somebody's busy diary. We all live such busy lives. We've got work, we've got family commitments, we've got social commitments. And there is a period of time you need to heal. And I generally say that you need to clear a month to 6 weeks, whereby you are recovering. Now, as we've got better at managing people's pain and function, and actually these days we've made a painful operation perfectly tolerable most of the time, we spend our time asking people to do less, because I want them to make a permanent return to function faster, as opposed to overdoing it a few weeks afterwards. Preparing one's home is important. Firstly, you will need a bit of care. You'll need a bit of help with preparing food, with somebody being kind to you, and there'll be times when you will really appreciate that mental and physical support. So having adequate care at home is a really key component.
And that really needs to be thought about if you live on your own, doesn't it?
Really does, actually. And very often people are embarrassed to ask a family member to come and spend a week, because they don't want to inconvenience them. But guess what? In life, you repay people with kindness over life, living as and so people are only too delighted to actually come and help a little bit on this brief period of time. And then often you can then manage, and a lot of my patients now drive between 2 and 4 weeks.
That's good.
Post knee, joint replacement surgery of the knee, and that allows them to be independent. So there is the optimization of that is very helpful. Patients often go up and down stairs the next day. So stairs are not actually a major issue.
No.
Of course, you can make things convenient. You might need plenty of ice in the fridge, because I like the use of a cryotherapy ice machine. You kind of want to have a fridge full of food. You want to have, your...
They sound small things, but they're so important, aren't they?
Really important. You want a pile of books you're going to read and movies you're going to watch.
You need to know where you're going to be sitting, because you'll be in bed part of the time. You're then going to probably be in your lounge. You'll be doing a bit of walking around. And you also need things quite near, don't you?
I think it's nice to plan these things. The truth is, we try and limit bed rest, but there's a lot of
sitting around,
sitting around and icing the knee and actually letting things quieten down. The sooner your soft tissue envelope settles with a nice supple range of motion post surgery, the sooner you get good functional recovery. It's not about muscle building.
No, absolutely. I think we obviously see lots of your patients for this prehab. I think swimming's a really good thing to get knees moving.
Yeah.
Getting on a bike, although often they're in pain, you can still normally get round on a bike.
Yes.
We do a little bit of strengthening, but just some mobility work.
Yes.
We always encourage people to sort of, be healthy generally. So, if you need a reason to give up smoking, this is probably a good reason before you're going for an operation. Try and keep the weight controlled, because we know afterwards, if you can reduce your weight, then that's going to be really good. And I think the other thing, talking about being mentally prepared, is we will go through with the patient the exercises we will expect them to do after the operation, but we'll do it before. Quite often I'll get them buying skateboards, because you can easily sit there and just bring your knee forward and back. And we'll go through, like, this is how you're going to use your crutches. This is how you get up and down the stairs with your crutches, and I think the more we can do with people like that, the more prepared they are, the less scared they are after. And actually, they're quite excited to get it done and get moving. But I think that's really important.
Absolutely. As you know, one of my sort of passions when it comes to the post-operative rehabilitation is the focus on two things. Number one is range of motion recovery, and the other is letting the soft tissues settle down. And if we have done a reasonable job at managing the pain and reducing the swelling, and range of motion is coming easily, I really advise my patients not to then do another 1,000 movements, because that is going to lead to swelling and pain.
Yeah.
If you can avoid that swelling and pain, you have a much easier ride. So if you're one of the ones who's doing really well, slow down and let it heal. Because when I see them at 2 weeks and they've got a well-healed scar and a supple range of motion, they have a much, much easier ride through what essentially historically was a difficult operation. Now, when it comes to the master physio, and I, as you know, work with master physios like yourself, it is the ability to take the very good patient and reassure them that they don't need to be doing any more to get a good result that actually is so valuable.
Yeah, I agree. I think the more I've been a physio over 25 years, and I think what I see against more junior physios is just that you're doing really well. We don't actually need to do any more. You're on this pathway. And you alluded to it earlier, is after the operation, and I know we've talked about this a lot, we want you to get as much bend as possible, in the long term. And we need to get that knee straight. And there's no doubt that we need to start doing this quite quickly after the operation. We don't need to do squats. We don't need to be doing lots of muscle building. You can always get that. And actually walking will help that. But getting that range of movement, and we've got lots of tips to help people with that, I think is absolutely key. But little and often.
Exactly that.
Every hour do 3 or 4.
Exactly.
And it will slowly come. Because you've got to stretch the knee, and that, you need to settle it down at the same time. So you've got to get that balance right.
My favourite phrase is really capsular stretching. And it's about gently getting you straight, gently getting you bent, and then quietening the soft tissues down. And which is why I'm so keen on the cryotherapy concept.
Yes.
And I tend to advise the use of the Physio lab machine, which is good. But remember, it's not icing, it's cooling. I actually cool the knee at about 7 degrees, which I find is the optimum temperature. So you're not freezing the tissue, but you're cooling it. And that, I think, helps reduce swelling.
And it helps with pain as well, doesn't it?
It does, because
I find that.
it absolutely reduces pain.
And the other things we often recommend, particularly when people are on their own, is you mentioned if somebody can stay for a week. I sometimes find, a couple of weeks, you might even need a couple of weeks, or obviously there are other rehab facilities that they can go to, but certainly people can't do this on their own, can they? They need that support.
They certainly need that support. Now, there are really 3 things that I look for in downstream physio. Number one is somebody who has done a lot of knee replacement rehabilitation, because otherwise the sporty physio may work on muscle strengthening, which then pushes a patient into capsulitis, and that is ongoing pain, and then they can't sleep at night. Number 2 is you want somebody who has seen it all before and is reassuring to the patient. And the third thing is I'd like a close relationship with that physio, so that if there is a problem, which there rarely is, we have an instant dialogue, and actually that is so valuable.
And because we've worked together for a long time, and you have with a lot of our physios, is they know that, and I think that's reassuring.
Exactly.
In itself.
And as you know, I work as a team with Barry Phillips, my lovely anaesthetist, and Christine, my nurse, and other caregivers. And that interaction between teams is so valuable. Intraoperatively, as part of the surgery, we've improved a lot of things. So the anaesthetic is not an either or. Generally, we give a combination of anaesthetic techniques. The patient is often asleep with a very light general anaesthetic or deep sedation. They have a spinal anaesthetic, which is really a thimbleful of local anaesthetic in the spine, which only lasts 45 minutes or so the patient can then move their legs pretty quickly afterwards. I put a lot of local anaesthetic into the knee in strategic places with other things like adrenaline and other drugs which reduce the bleeding into the knee. And we keep the surgery to a minimum time. And we've headhunted and put together a team in theatre that have done tens of thousands of knees, and that means that the surgery need not be very long, and that reduces the soft tissue insult to the knee. And really, I treat this as a soft tissue operation with some resurfacing bits going in, as opposed to something that is a very prolonged metal-based operation. You see what I mean? And then finally, one of the things we do is we use infusions of local anaesthetic, which can then help mitigate pain. And so a combination of lots of different things, both in anaesthetic technique and surgical technique, and then perioperative management of being very bespoke in the way we give people pain relief, actually cushions people through what traditionally was very painful, and actually under our care is much less painful.
Well, I can speak on behalf of my family member that you did a knee replacement on, and she couldn't believe how little pain she was in after those first few days after. She said, I can't feel my knee. I don't feel any pain, which meant she could get it moving straight away. So from a physio point of view, and I always say to people, you are given medication, unless you're going to have a reaction to medication, they're doing all of these things to help your pain. So make sure you take them and use that as a window of opportunity to get the knee moving. Because if you don't get the knee moving in 4 to 6 weeks, it can be really hard to get that knee going again.
I think, Chris, the truth is, as we've become better at this through marginal gains, we find most of our patients are doing very well, and therefore we spend most of our time asking them to slow down a little bit. Because the truth is that really horrible, stiff and painful knee that used to exist, at this level of elite care and integration, you see less and less of under our care. And therefore, what we then try and say is, you're doing so well, can you please be lazy and not over-exercising, particularly week 3 and 4? And so we like a good functional recovery. We say you can drive, you can go and meet your friend for a drink or dinner, but don't walk 2 miles and then go and do that.
Exactly.
Because if the anger goes out of the knee, they sleep better, they get their day-to-day function back, and they sail through this and then have a much more successful outcome.
With any recovery, you want a nice, smooth recovery. You don't want, episodes of pain which put you back, and often, as you say, that's when people overdo it.
Well, capsulitis is really the enemy, because if somebody has done it and they've got a painful joint at 4 weeks, there's often not much, we can't do much, and often it then takes longer for it to settle. Very often when I do both knees, I do one at a time, and the second time the patient comes to you, they absolutely know how to pace it.
They know everything, don't they? Talk us through how long do patients stay in hospital for normally with you?
So generally it's about 2.5 days. You can send people home earlier, but the truth is we're trying to get this right once every 30 years in their life, and therefore we don't emphasize just getting them out of hospital, because this is about end-to-end care.
And also, the infusions have to be done in a hospital. So to get the proper pain relief,
I think that's absolutely right. And so the truth is, you want the wounds to be healing nicely. You want the patient to be confident. We don't want to shove the responsibility of their perioperative care onto their friends and family, and we want to look after them. And so I tend to, my average length of stay is, I think, about 2.2 days. Which is not very long in the large scheme of things, but shortening it, there is no benefit, and actually it could be detrimental, couldn't it, if you just
as you say,
I think
throwing people out. Not to,
I think each patient will. Some want to go home the day after surgery,
Yeah.
and some might need an extra day. But you have to be bespoke on this journey. This is all about bespoke care.
Yeah. Talk us through what a patient would expect on the day of their surgery, because that's quite often, I think being mentally prepared is about knowing what's going to happen on the day. So talk us through what would happen on a, I'm sure you've got many knee replacements this week, so people are coming in. What time do they come in? How does it work?
So generally, on an operative day, patients either come in very early in the morning or they come in around midday. And there are two tranches. And generally that is because you can't stop after every operation and then come up and do all of the methodical things you need to do to prepare them. They will be seen by myself, my anaesthetist, Dr. Barry Phillips, normally the senior nurse checking them in and checking that they're ready, a physiotherapist who might tell them what's going on, and indeed, actually, very importantly, the dinner lady who will get their order in to know what they'd like to eat when they're awake and they're wanting to move on.
Yeah.
And these 5 people very often will come and see them beforehand. We normally are very precise on our surgical timings, so patients will know the time they're expected to go to surgery. And we like them drinking water up to 2 hours before their surgical time and eating well up to 6 hours before their surgical time. And sometimes you see the patient hasn't had anything for 12 hours the day beforehand.
Oh, gosh.
And then on the day of surgery, they are starving by the time they come in. And that's because they weren't hungry and they were anxious the day before. No, it's important to know that you have good calories and you're well hydrated before you start the journey.
It's a long day, isn't it?
It's a long day, and they need energy to heal. So that's really on the day of surgery. Patients are understandably anxious, but this is really not an operation they need to be anxious about. We do it all the time, and we look after them really carefully, and we generally reassure them in that.
And that evening, do they get up and go to the loo? How does that work? The physio comes round?
No, very much so. We've adapted our techniques so that patients can mobilise early. So generally, my patients will get up and walk within 2 to 3 hours of surgery, and they are able to fully weight bear.
Yeah.
And
with crutches at this point?
Generally with walking aids, because as you put the local anaesthetic around the knee, sometimes the muscles are not quite as strong in their recovery, or they're recovering after the anaesthetic.
Yeah.
So we want to make sure that they're not overconfident.
So, but in theory, the knee replacement is 100% secure enough. It's not because of that, is it?
Absolutely right.
Yeah.
So there are 2 things that are taken into mind. Firstly, most joint replacements these days are cemented in place, and the cement is set. So it's going to be as strong when they stand up as it is going to be in 10 years' time.
Yeah.
And the second is, we are very, very careful in the way we close the soft tissues, and we do that in layers so that actually that is robustly done. So there are no issues with that. And I think weight bearing is good because it reduces blood clots and chest infections and all of the other things. And really, this is an operation you're doing on somebody relatively well. It's not an emergency. It's an elective operation.
Yeah.
And getting up and going gives them tremendous confidence.
Yeah.
We then basically put the ice machine on, and they are then they're into that next phase of managing their soft tissue recovery.
And you will encourage movement straight away, won't you?
And you encourage movement, but you want to get that balance right. So once they know that they can move it, they're then not doing 1,000 exercises, because otherwise you then get swelling. So there is a balance to be
And even
struck.
just sitting on the edge of the bed, you're bending your knee.
Absolutely.
There's lots of simple things you can do.
Lots of simple things, but
improve that range of movement.
But as we've managed the pain scores, and I see patients' pain scores under our care might be 0 or 1 out of 10 pain.
Yeah.
Actually, in that scenario, you just want them to ice it.
And you've got lots of tricks, haven't you, around if somebody's pain, comes up to a 3 or a 4, you've got lots of options to help that individual.
Yeah, I mean, Barry and I have continuously learnt over to date in 2024. We've done about 7,000 knee replacements, and we are continuing. We do about probably 600 to 700 a year of partials, fulls, and revision knee replacements. And we're constantly learning. The key is that you need patient-centered analgesia. That means you need to give patients pain relief on their timetable, not on yours.
Yeah.
Some people are sensitive to opioids. 3 in 10 people might be very sick or get constipated on opioid analgesia. Some can take anti-inflammatories and some can't. And so you need to be very bespoke. You also need to predict the downsides of each and every drug.
Yeah.
You know, you've got to mitigate things like constipation. And dizziness and nausea. So we give other things to mitigate, and you manage, and patients fall into a spectrum.
Yeah, absolutely. And so they're in for sort of 2 to 3 days. Obviously, they see their physio, and then they're going to generally go home with some support. And then obviously we see lots of your patients in home as well, because they need to continue on with their physio, don't they? We have to get that balance right between restoring range of movement and not irritating it. And I think that's one of the key things.
I think that's exactly right. I think one manages their soft tissue recovery.
Yeah.
And ideally what I want to see at the 2-week stage is when I see the patients after they've gone home, I want to see a well-healed scar, a supple range of motion, and a soft tissue envelope that is settling nicely. And if I have those 3 things, they are on track to make a wonderful recovery.
Perfect. Being prepared and having everything ready at home is really important, and it needs to be a safe environment to go back to. I've actually got an email here from one of our patients who bought a shoehorn to help her, a sock aid, she raised her toilet seat, and she bought non-slip mats for the shower and the bath. She had ice packs, ice wraps. She uses HelloFresh. So she started to get more deliveries in of those, those, I don't think it's, frozen food. She arranged transport to make sure that she could get in to see you. And it's just all those little things that actually you can't sort it out after the operation. It's got to be sorted out before.
Well, she sounds perfectly prepared for that. And really,
she moved her rugs in case she tripped as well.
I mean, one of the most important things there, of course, is have friends and family there to actually support you and have a cup of tea with, because the journey of recovery isn't always smooth. You have ups and downs. There are days when you feel more tired, days when you feel more pain, and you kind of need somebody who's encouraging and positive, and sharing your journey with you. And I find that a very useful thing for patients.
So let me just go through a few things around recovery, Sam. So how long generally would you say that and these are generalizations, everybody's different. How long would you say that your patients are using crutches for?
So generally most patients would use walking aids for probably 2 weeks. Maybe 1 stick for a 3rd week. If they need it. It's almost...
It's only when they go outside, I think that can be useful.
And actually, the truth is, most of the time, if things go well, we're doing it to slow them down a little bit. Because that is the key. If you can not overexercise week 3 and 4, if you're doing really well, you then have the dream run. One of the key things is sleeping at night. And most people have sleep disturbance for about 6 weeks. Occasionally, it is a bit longer, and sometimes it's shorter. But when you sleep well at night, you're then functioning better during the day. And so... again, that is about soft tissue management. Driving liberates people. So if you can drive safely, and the party line is you've got to be able to do an emergency stop safely. And your friends and family need to be able to vouch for that. And I think most of my patients will find that they can do that between week 2 and week 4. And then generally things like golf or hitting a tennis ball is roughly between 6 and 8 weeks. Again, one is very bespoke about it.
I think it's important that, because patients will always ask us that, won't they? When can we do this? And we give an answer, but in our heads we're thinking it will happen when it will happen. And actually for you, it might be slightly earlier, it might be slightly later.
Well, I'm really interested in people, you see. So I enjoyed that interaction. And the truth is, you're an avid golfer, and I treat a lot of golfers because, of course,
you play
golf. It's one of my sporting passions. If they're doing really well, then I'm trying to think about how do I hold them back a little bit so that they don't give themselves the capsulitis. So I might then say, why don't you go and chip and putt at 4 weeks
Yeah.
and have a drink with your friend at the club
Yeah.
at 4 weeks?
Yeah.
And suddenly, when they go back at 6 weeks,
Yeah.
firstly, they've seen their friends and they don't
Yeah.
quite feel like a patient. But actually, their short game is pretty good.
Yeah.
Because
Yeah.
they've actually spent some time practicing that.
Absolutely. I think it's sensible, isn't it? When don't go from nothing to everything.
Exactly.
Don't go around 18 holes without a buggy. Like, break it down. The other thing that I often get my patients to do is to look on their phones, because every phone now has a step count.
Yes.
And I think it's quite nice for people to see a slow, gradual increase in their step counts. What you do see is you go, oh, it's quite neat. It's quite sore on Saturday. We'll just have a look at your phone.
Yes.
Oh, on the Friday, I did 20% more steps than I'd done ever before.
Yes.
And so I think that can be a nice way of monitoring that gentle progression of mobility as well.
I fully agree, and I think the other thing that patients find is if they do that, overdo it on the Friday,
Yeah.
it's interesting to know how long that effect lasts. Actually,
Yeah.
because does it take till Sunday for it to settle down?
Yeah.
So it's very interesting. Interesting, the evolution of looking on your phone is the wearable technologies
Yeah.
that are coming into my industry, and along with robotics, the wearable technologies represent an interesting angle where it monitors not only steps but heart rates and pain scores and gives instant feedback. And I'm involved in developing some of these things.
Data collection at the end of the day. And
Data collection.
that can be very useful.
Yeah, and I think it'll go back to feedback on precision on robotics as well as on outcomes, and enable us to get better and better and learn lessons, really.
Yeah. So in summary, Sam, what are your top 3 tips for a knee replacement?
Firstly, you need an accurate diagnosis. So the top tip is get an accurate diagnosis and speak to somebody who can give you an honest answer about the pros and cons of all of the different modalities open to you. Be that be conservative, be that be injectables, be that be surgery.
Mm-hmm.
Make sure that the plan...
Is this number 2?
Number 2
Yeah.
is make sure that the plan is robust. So if you have unicompartmental disease, a unicompartmental replacement is going to be brilliant. Yeah. If you have bicompartmental disease or tricompartmental disease, you need something else. And make sure that the person you're seeing has done lots and actually has very good results, and they need to be able to show you their results. Mm. And these days, we've got something called the National Joint Registry in the United Kingdom.
Yeah, that would be good, yeah.
Which has, since 2003, logged about 3 million data sets.
So to be clear, every knee replacement in the UK in private practice in the NHS is logged at the Joint Registry.
It's logged at the Joint Registry. The caveat is if you're an international patient, it's not logged.
Fine.
So
you can go and see how many of these operations your specific surgeon has done that year.
That is correct.
Obviously, you don't want somebody who does 3 a year.
Yeah. Yes. I mean, generally, as a broad rule of thumb, the more you do as a surgeon and the more a team you have, the better you are.
Yeah. And
you can see on a website called njrsurgeonhospitalprofile.org where what your surgeon is doing per year.
And outcomes as well.
Well, you can't really see the outcomes on that.
Right.
For the outcomes, you need to ask the surgeon what their revision failure rate is and what their complication rate is. And in the UK, we have a well-governed expert medical fraternity.
Yeah.
And who are normally transparent and honest. So I think most people will say, this is what I've done, and these are my outcomes, and these are the complications, and these are the pros and cons. So I think you've got to do your due diligence on who you're seeing.
That's a very good tip. And the last one, Sam? Tip 3?
Tip number 3 is plan your recovery carefully. This thing doesn't fit neatly into your diary.
Yeah.
Make sure that you and your surgeon and the team are fully aligned. We're going to get it right the first time.
Yeah.
Because that is the best chance of getting it right.
Yeah.
And then you can enjoy the functionality of a well-done joint for years.
Yeah.
And forget about it. And the ultimate compliment somebody can pay is the forgotten knee.
Yeah.
But make sure that you concentrate on getting it right the first time and put the arrangements
Take your time, prepare yourself.
Get the right team around you.
Do it at the right time to give yourself that recovery time, because we know it takes
and the right team.
Yeah,
with the right expertise.
Yeah, perfect. Well, I think they're very good tips then. Thank you very much.
Thank you for your time, Chris. Lovely to be here.